Yes, ma'am, we can hear you, ma'am. Good afternoon, ma'am.
Yes,
Hello,
please,
good
we hear you.
afternoon. Good afternoon, ladies and gentlemen. Can you hear me?
Yes, please,
Yes,
we
ma'am.
hear
Good
you.
afternoon, ma'am. We can
Okay.
hear
We
you.
can hear you. We can hear you.
So, good afternoon, ladies and gentlemen. Welcome to another interesting PAN webinar series, which is organized in collaboration with the Nigerian Society of Pediatric Oncology, NISPO. Today, we have a very interesting topic to discuss. They have a very interesting topic to discuss, which is stroke in sickle cell anemia. To start off, I'd like us to give the floor to the PAN president, Professor Anaemia, to give a brief welcome address. Ma, you have the floor.
The PAN Secretary, Dr. Chikaduru, the other members of PAN ESCO in the room, NISPO executive, ably led by Dr. Akishete, who I must say had a lavish 50th birthday celebration yesterday. Happy birthday to the president. The moderator of the day, our own IPP, Dr. Olufemi Ogunride, Speaker of the day, Dr. Bath Chuku, PAN elders, esteemed members, both at home and abroad, our partners and friends of child health. It is my pleasure and honor to welcome you all to the 5th webinar in the 2025 PAN Educational Webinar Series. On behalf of the Executive Committee and the entire membership of PAN, I thank you for joining us today for this important discourse focused on stroke in sickle cell disease, a tale of sickle cell assault on the brain. Now, sickle cell disease remains one of the most pressing genetic and public health challenges in our region, and stroke is among its most devastating complications, often striking in early childhood and leaving lifelong consequences. In children in Nigeria and Black children generally, the leading cause of stroke is sickle cell disease, where 6 out of 10 children with stroke actually have sickle cell disease. Today's theme not only highlights the clinical urgency, but also the human impact of this preventable and manageable outcome if appropriate measures are in place. This webinar comes as a response to observation number 10 of the communique of our association following the unforgettable Gombe Pankov in January 2025. What was that observation? We said we had observed that there are significant barriers that still exist in the optimal care of children with sickle cell disease. This webinar is therefore part of PAN's sustained effort to build capacity, update knowledge, and strengthen the pediatric community's ability to deliver evidence-based care across Nigeria and beyond. Our commitment is unwavering in ensuring that every child with sickle cell disease has a chance to live a full, productive life free from preventable neurological injury. We're privileged to have with us today people who have experience in the diagnosis, management, and prevention of this problem we want to talk about. So I encourage active participation and engagement throughout the session. At this point, I want to sincerely appreciate Novartis for their generous sponsorship and continued partnership in driving pediatric health forward through support for knowledge-sharing platforms like this. As we proceed with today's program, let's remain reminded that with every insight we gain, Every protocol we improve, every case we present, we take one step closer to securing the brain health and future potential of children living with sickle cell disease. Thank you all for being part of this transformative learning journey, even as I hand over again to the secretary to call on the moderator and speakers to proceed. Thank you, NISPO, for taking up this responsibility. Over.
Thank you, Ma, for that warm welcome address. We would like to hear from the president of the Nigerian Society of Pediatric Oncology, NISPO, Dr. Adesheye Akinshete. Sir, you have the floor. Thank you.
Good afternoon, everyone. Thank you, President of PAN, Dr. Ekure. And thank you to everyone who is on this call this afternoon. We'll be speaking on this topical issue, and we hope that at the end of this interaction, we will get the benefit to improve our different practices. Thank you for an engaging time.
Thank you, sir. Thank you, sir. At this time, I'd like to call on the moderator for today's session, none other than our immediate past president, Dr. Olufemi Ogurinde, a professor of pediatrics. He will be introducing the speaker and also taking over the question and answer session. Thank you, sir. You have the floor.
Thank you very much, Madam Secretary. I would like to stand on existing protocols. Good afternoon, distinguished elders of PAN and ISPO, and members of PAN, ladies and gentlemen. Let me start by thanking the powerful presidents of PAN and ISPO for their very warm welcome. And I also like to say hearty congratulations to both of them, our PAN president on some lofty appointments at the International Pediatric Association, and the NISPO president for recent elevation and also the recent addition to his lifespan. I pray that God Almighty will continue to bless your ways. I will soon be introducing the speaker for today, but first of all, let us know the agenda that we are running. We are going to have a 40-minute lecture, and it will be followed by a 15-minute question and answer session. After that, there will be a 10-minute presentation by Novartis. I want to implore all of us that in order not to make this meeting a rowdy session, let us keep our mics muted when we don't have the floor. I want to believe that the host and the co-host will handle the situations appropriately. I mean, if anybody stops us, I hope that we will handle that situation appropriately. At the end of the lecture, questions will be asked, and the floor will be yielded to persons that raise their electronic hands. Questions may also be submitted in the chat box. And if there's any, I'm not sure if there's any Q&A box. Okay, I think questions will be submitted in the chat box, and then we can harvest from there. I want to plead that questions should be brief and straight to the point, so that we can maximize I think 15 minutes for question. I think the more people asking questions, the better. So let me also say that our rapporteur for today is Dr. Ahmed Bezu Saleh from Abubakar Tafawa Balewa University, teaching hospital in Bauchi. He is the current head of the hematology oncology unit in that institution. So to our speaker today, Dr. Professor Bath Chukwu, I hope that he's in the house. Very briefly, he's a human pathologist too. I mean, apart from being a pediatrician, he's a professor of pediatrics at the University of Nigeria, Nsukka, consultant pediatrician, and also working in the hematology and oncology unit, obviously. So, Prof, if you're in the room, you have 38 minutes actually, because I need to give 2 minutes to the rapporteur to summarize, hopefully, a very beautiful lecture. When you have spent 30 minutes, I will give you a heads up so that you know that time is almost up. So at this point, I would like to yield the floor to Professor Buff. JP. Professor Buff, Chukwu.
Thank you, sir, Professor. I'm very grateful to PAN and to NISPO for giving me the opportunity to speak this afternoon. Thank everybody who is in this house. Can my slide be shared?
Hello, sir. No problem. We couldn't see the slide. Hello?
Yes, can I share the slide?
Yes, you can. Yes, yes, bro. Yes, sir.
So can you see it now?
Yes, but not
Yes,
his. Yes.
yes, bro. We can see.
Okay. All right. It's off.
Prof is on, but you need to share in a slideshow.
Okay.
Thank you.
I'm not having.
At the very top towards the left, you will see the icon there, the fourth icon.
Yeah.
There's a triple at the very top of your screen. You will see the fourth icon.
Bro, at the top of the where after home there is insert design, you follow there is a slideshow.
Yeah. Let me share again.
Dr. Chukwu, can you drop your presentation with the secretary? And then she can show it if we have a problem. Perfect.
Yeah, perfect.
Can you see it now?
Yes, we
please.
can.
Okay. All right. So good afternoon. As I've said, let me just go straight to the presentation. We'll look at the outline. We have a brief overview of sickle cell disease, importance of neurological complication. Then we enter in the stroke proper. We look at stroke prevention, prediction and prevention. Then we conclude, probably evaluation. Okay, as we know, sickle cell disease is an autosomal recessive disorder of hemoglobin where there is just a single point mutation at the sixth codon in the beta globin gene, in which there adenine is replaced by thiamine. Therefore, instead of coding for glutamic acid, which is a hydrophilic amino acid, it will now code for valine, which is a hydrophobic amino acid. And with this, when there is oxygenation, normal hemoglobin should be soluble. But with sickle hemoglobin under deoxygenation, it will crystallize and form tactoids and distort the shape of the red blood cells. giving a heterogeneous morphology. The typical example is the sickle-shaped cell, from which the name was derived. So if you look at this, these are normal cells, which are discoid in shape, and then the sickled cells. Now, what are the characteristics of these sickled cells? They have reduced deformability and malleability, which impairs them to pass through the microvasculature. They also have this characteristic of adhering to the endothelium. So there's enhanced adhesion to the vascular endothelium, and they also adhere with each other and with other cells, leading to vaso-occlusion. There's also increased hemolysis with reduction of lifespan of the red blood cells, leading to chronic anemia. Now, these features are responsible for nearly all the features and complications of sickle cell anemia. Now, but for the purpose of this webinar series, we will focus on the neurological complications of sickle cell anemia. What are the importance of the neurological complications? Neurological complications, particularly stroke, is common in children with sickle cell anemia and is a major cause of morbidity and mortality. It has been shown that up to 11% of children with sickle cell anemia experience overstroke before the age of 20 years. Not just overstroke, they also what we call silent cerebral infarcts, which occur in up to 39% of these children. And this silent cerebral infarct contributes to cognitive and academic decline in children with sickle cell anemia. What are the pathological types? Well, first of all, let us define what is stroke. It's a sudden death of cerebral neurons due to ischemia or hemorrhage into the brain tissue. And we have the ischemic type and the hemorrhagic type. In children with sickle cell anemia, majority of cases is due to ischemia. In fact, more than 80% is a result of ischemia. And then just about 3% of hemorrhagic stroke. Hemorrhagic stroke is common in older children and adults. So what is the burden? As I've said, 11% will develop ischemic stroke before 20 years, 3% hemorrhagic stroke. In Nigeria, studies have shown that stroke occur in about less than 1 to 5% of children with sickle cell anemia. These are studies done by Lagunju as well as Madu et al. If somebody is controlling, can you move to the next slide? Okay. So stroke is commoner in children less than 6 years and less in those less than 2 years. If a child has stroke, there's a 67% chance of recurrence if nothing is done to prevent reoccurrence. And children with hemoglobin SS, that is sickle cell anemia, are 300 times more likely to develop stroke compared to children with normal hemoglobin. What are the risk factors? I've said 2 to 5 years, age, male sex, a child who has had previous stroke or transient ischemic attack will more likely have stroke. Low hemoglobin, recurrent acute chest syndrome, leukocytosis. But the most important risk factor is when there is abnormal cerebral blood flow. Next slide. What is the pathophysiology? All arise from the sickle red cells. As I said, it has a tendency to stick to the endothelium. And when it does that, there is some endothelial injury that occurs. There is also hemolysis, which releases free hemoglobin, which is also injurious to the endothelium. and also scavenges nitric oxide, which is a vasodilator. So with this endothelial injury and release, this endothelial injury is mediated by some cytokines, P-selectin, vascular adhesion molecule 1, and integrins. With this, a kind of pro-inflammatory condition arose, and therefore, more cells, especially the leukocytes, will now get to the injured sites, adhere, and they release more inflammatory cytokines. There's also platelet aggregation around the injury, and therefore, at the end, because of the inflammation which goes on, there's proliferation of smooth muscle cells, and fibroblasts within the intimal layer of the vessels. There may also be thrombi formation. And all this will lead to, because of the chronic inflammation, there will be narrowing of these vessels and may eventually lead to stenosis. Next slide. Now, when we come to the silent cerebral infarcts, this occlusion of large vessels may not explain them, but studies have shown that their microinfarcts are noted in deep white matter with diffuse arteriolar thickening in children who have CVA, who have neuropathological CVA, but with normal angiogram. So these ones occur in the deep white matter, and angiogram may not detect them, but these are pathological studies that have been found. Now, these silent cerebral infarcts, though they are silent clinically, but they have some significant effects on the children. They may be associated with decreased IQ, they may have poor academic performance, and they may have impaired memory and some executive function. And without high index of suspicion, these impaired functions may go undetected. Next slide. So what are the clinical presentations of stroke? Of course, obvious stroke, almost everybody can recognize that. There may be sudden loss of speech, depending on where the stroke, which part of the brain it occurs. There may be impaired hearing. Patient may complain of headache. There may be altered consciousness, loss of vision. And the one that is obvious is when there is weakness, paralysis, or paraplegia, especially of one side of the body. Others can present with seizures. Next slide. Now, how do we diagnose that? Of course, it's mainly clinical, but some imaging studies may be done. Angiography will tell you where there is obstruction, but of course, we know that it is invasive. MRI can also detect microinfarcts. CT scan of the brain is also another imaging study that can be done. If we look at this CT scan, we can see this child. These are areas where there are infarcts. In fact, almost one side, this side of the brain is gone. Look at this side. This child presented with quadriparesis. We are having recurrent CVAs. Next slide. So how do we manage stroke in the acute states? Once a child presents with stroke, your aim, the damage has been done, your aim is to do urgent EBT, exchange blood transfusion, aiming to reduce the quantity of sickle hemoglobin to less than 30%. And you can estimate this by when you do the EBT, you take pre-EBT blood sample to quantify the different hemoglobins using the HPLC. So when you finish, you take sample, do the hemoglobin quantitation, do the EBT, take another sample, and do the quantitation so that you know the effectiveness of the EBT. And you continue until you aim to reduce it to less than 30%. Now, this will improve oxygen carrying capacity as well as reducing sickling. You may also need to hydrate them, give oxygen where it is necessary. Then analgesics are also important, anticonvulsants where there is need for that. But the management also is not just the pediatrician, it is a multidisciplinary approach involving the hematologists, neurologists, radiologists. Physiotherapists are also important, psychologists are all partners in the management of a child with stroke. Next slide. Now, how do we predict that a child may have stroke? We do this by doing transcranial Doppler. Transcranial Doppler measures the cerebral blood flow velocity in the internal carotid arteries. And it is a major predictor of CVA. That's the blood velocity. It's a major predictor of CVA, as I've said. And it can detect where there is focal stenosis. And when there is stenosis, of course, the blood flow velocity will increase. If you look at this formula, velocity is dependent on the flow rate as well as cross-sectional area of the vessel. So when there is the cross-sectional area has reduced by stenosis, of course, the velocity to the brain will increase as the body is trying to compensate by supplying more blood to the brain. So this is a picture of transcranial Doppler. This is where it's being done. It is done using probe to identify what we call acoustic windows, where the skull is thinnest, and the commonest area is the transtemporal window. We also have occipital window and the ophthalmic area, but the commonest site is the temporal window. This is how it looks like. This patient has a velocity of 189, so it's a high velocity. Next slide. So how we categorize the results of TCD? The normal value is 70 to less than 170. We say the velocity is normal. When it is between 170 and 199 centimeters per second, we say it is conditional or borderline. And when it is 200 cm per second, we say it is abnormal. And children with sickle cell disease have 40 to 50% higher mean velocity than children who do not have that. So normally children, of course, have higher velocity than adults because of their increased metabolic rates. And we also know that children with sickle cell anemia, that's hemoglobin SS, have higher velocity than those with S thalassemia and hemoglobin SC. It has been found that stenosis is associated with flow velocity 2 to 3 times higher than normal. So when there's stenosis, of course, the velocity increases, as I've said, trying to overcome the stenosis. With TCD, it has been predicted that those with normal velocity 70 to 170, that's normal velocity, has 9% stroke-free survival. Those with conditional velocity have 97% stroke-free survival, and those with 200 above have 83% stroke-free survival. And children with velocity of 200 and above, that's abnormal velocity, have a relative risk, 40% relative risk of stroke within 3 years. Those with conditional would have 7% relative risk of developing stroke. And therefore, and those with normal velocity had just 2%. So we must strive to make sure that the cerebral velocity is within normal so that we can significantly reduce the risk of stroke. Next slide. Now, some studies in Nigeria have done looking at the cerebral blood velocities of children with sickle cell anemia. In Lagos, a Sickle Cell Foundation, this study was done in 2017 by Adekunle et al. And they noted that 10.8% of children who had transcranial Doppler had abnormal velocity. In Abuja, Chukwuoji et al. Also found 6.9%, and in the northwest of Nigeria, 9.3%, and in the southeast, Modebe and Co. also noted about 6% of children who had transcranial Doppler had abnormal velocity. And 10 to 20% of these children had conditional velocity. And we know that this conditional velocity can progress to abnormal velocity. Or some of them can reverse, but if nothing is taken, no care is taken, then we move to abnormal velocity, therefore increase the risk of stroke. Now there's a guideline in which TCD guideline for preventing stroke. The guideline gives priority to children with hemoglobin SS. That's what I say, they have a higher risk than other genotypes. And children between 2 to 16 years are in the group that you must do the TCD, because this is the age group where the risk of developing stroke is higher. Now, if the TCD is done and you have normal velocity, it should be repeated after 1 year. If it is conditional, we repeat it after 3 to 6 months. And if it is abnormal, you just give like 1 to 2 weeks and repeat it so that you confirm that it is actually abnormal, because there may be other factors that may affect it. So if you repeat it and it's still abnormal, you must do something because stroke is imminent. So next slide. So how do we prevent stroke? One is by regular blood transfusion. Once a child has had stroke, you've managed immediate condition. The next thing is for you to start the child on regular blood transfusion, because the risk, as I've said, is high. Risk of recurrence is high. Also, if you have done the TCD and it is above 200, you also need to start the child on regular blood transfusion. That means every 4 weeks, you transfuse this child, either by EBT, or if it is not possible, by normal blood transfusion. And you aim to reduce it, the sickle hemoglobin, to less than 30%. And when you do that, the chances of recurrence of stroke and even other complications will be markedly reduced. It has been shown that regular blood transfusion reduces occurrence of stroke by up to 90% and lowers abnormal and conditional TCD velocity to normal. So if a child has had abnormal TCD and you start on regular blood transfusion, it's going to lower the blood velocity. I mean, send it back to normal, and therefore reducing the chances of recurrence. But when you are doing the regular blood transfusion, you take cognizance of iron overload and institute measures to reduce that. Another alternative, or which may be an adjunct to regular blood transfusion, is starting the child on hydroxyurea. And it has been shown that hydroxyurea lowers TCD velocity in children with sickle cell anemia. This was demonstrated by Lagunji et al. In 2015. And it also prevents conversion of conditional TCD to abnormal velocity, thereby reducing the relative risk. Well, I won't go to bone marrow transplant and gene therapy because everybody knows it's still high falutin in our environment. But of course, if that can be done, it's going to cure the child, and therefore we won't be talking of stroke from sickle cell anemia again. Next slide. Now, I just want to bring this slide, substances that are still under investigation. Now, I talk of omega-3 fatty acids, which have been shown that in mouse model, it causes a reduction in neutrophil counts and reduces endothelial activation. Of course, we know from the pathophysiology we have said there's inflammation, and when there's inflammation, a lot of neutrophils, endothelial injury, activation, inflammation, and all that. It has also been found to reduce both local and systemic inflammation and have protected against sickle-related end organ damage. It has also been found to inhibit expression of P-selectin, ICAM-1 interleukins. These are pro-inflammatory cytokines. There's also another substance, potassium thiocyanate, which has been shown to inhibit sickling in children with sickle cell anemia and improves hydration of red blood cells. This is in vitro. And has been shown to work synergistically with omega-3 fatty acid to reduce inflammation. Well, there's a little study we did in Enugu. We had to get two groups of patients with sickle cell anemia. One group is given just the normal routine drugs that we give. And also the second group, we're also giving the normal routine drugs and then added omega-3 and potassium thiocyanate. So we didn't remove the normal routine drugs from this second group. The next slide. Okay, and we found out that the TCD, those with conditional TCD velocity converted to normal. And some people it also prevented the conversion of normal conditional TCD velocity to abnormal. So that's what we found, but it is still under investigation. More studies are going on that. Now, what are the challenges of stroke prevention in our environment? One is the availability of TCD machine and the personnel. Not many centers have it. What are availability, accessibility, and affordability of blood products in our environment? That's still not optimal. Well, I'll play down on that because those hydroxyurea, is it fully available and affordable? Not so. So we say that while we conclude, we say that stroke is common in children with sickle cell anemia, and it is predictable when we have TCD, and it is also preventable by regular blood transfusion, hydroxyurea, plus or minus omega-3 fatty acids and potassium thiocyanate. So we may recommend that TCD, probably with PAN, TCD machine should be available, even if not in all health facilities, at least there should be one in every state. We should make blood transfusion easily accessible. Hydroxyurea should be accessible. And there's a lot of burden of sickle cell disease in our environment. And we should strive to see if treatment for children with sickle cell anemia should be free. And we try to create awareness to health professionals, caregivers, and general public about sickle cell disease. Thank you so much for listening.
Thank you very much, Professor Bath, for that very lucid presentation. I think, so we don't waste too much time. I will immediately yield the floor to Dr. Sadley for the summary. Thanks very much, Dr. Bath, for saving us a lot of time. So, Dr. Sadley, please, can you give us a summary of the presentation before you go on to the questions?
Okay, sir. Good afternoon, everyone. My name is Dr. Ahmed Faiz Sadley. I'm giving the summary of the presentation. So we had a very beautiful presentation that was started by a brief overview of sickle cell anemia, where the main highlight there is the autosomally recessive of the presentation, the point mutation that occur as a result of changing of a hydrophobic glutamic acid to a more hydrophilic valine, which is the main issue in sickle cell anemia. And also there, it was also highlighted the main problem with sickle cell is the reduced deformability leading to enhanced adhesion, and then hemolysis with reduced lifespan of sickle cell anemia patient. Then we also look at the type of stroke in sickle cell, where it was highlighted that 80% of the stroke in sickle cell anemia is as a result of ischemia, and then only 3% is due to a hemorrhagic stroke. While in Nigeria, it was highlighted that the prevalence of stroke in sickle cell anemia is about 1 to 5.4%. Then there we are also look at the risk factors of sickle cell anemia, where we highlighted age, sex, previous history, decreased hemoglobin, increase the WBC count, and then abnormal blood flow. And then it was also shown, it was also highlighted that sickle cell is commoner in children less than 6 years, with more aggressive in children less than or equal to 2 years. And then 67% of sickle cell have recurrent. And then those with sickle cell anemia have 300 times likely risk to develop stroke compared to those with normal hemoglobin. We also delve into pathophysiology of sickle cell, where we look at vascular adhesion, hemolysis, and then endothelial damage, which lead to the most of the consequences of sickle cell anemia patient. And then here also, Prof also talk about silent infarct that occur in large vessels, which highlight some of the presentation of silent infarct include a decreased school performance and then impaired memory. Then we also delve into the clinical presentation of sickle cell anemia, which the main point there is the main clinical features is as a result of severity and the area of the brain affected. So patient can present with various types of presentation depending on the severity and patient and site of the brain affected. And then also we talk about diagnosis, which Prof highlights. The diagnosis is basically clinical, but MRI can detect some micro impact, and then angiography is also essential, and then CT scan also can also be done. Then after that, we go into management of sickle cell anemia, where we look at acute management, which shows that we need to be doing exchange blood the role of exchange blood transfusion and the hydroxyurea were discussed as important, hydration and then oxygen analgesia as important acute management. And also Prof highlighted that if you are doing EBT, you have to target reduction of hemoglobin S by less than 30%. Therefore, you need to do pre and post exchange blood transfusion HB access to make sure that that is properly achieved Also, Prof highlights the importance of multidisciplinary approach in the care of sickle cell anemia with a stroke. Then also, after that, we went into predictors of a stroke and how to prevent stroke also. So we look at blood flow as the major predictor of a stroke in sickle cell anemia. And to detect that blood flow, we can use transcranial Doppler, which is used to detect the blood flow. And then Prof went ahead to categorize transcranial Doppler into normal, conditional, and then abnormal. The normal is less than 170 and abnormal is 200. In between that lies the conditional. And there is a study that shows that the normal velocity is far higher in those with sickle cell than compared to other genotype. And then also Prof look at predictors of stroke in a sickle cell anemia patient. And then we also go through the STOP guideline for the primary prevention of sickle cell anemia, where we look at when to do TCD in those with 2 to 16 years. And then if it is normal in them, we repeat in 1 year, or if it is conditional 3 to 6 months, and then abnormal, we can remove 1 to 2 weeks. We can repeat 1 to 2 weeks. If it remains abnormal, then we should discuss on way forward on how to prevent stroke in that patient. Then also we go into stroke prevention proper, where we look at regular blood transfusion, use of hydroxyurea, bone marrow therapy, and gene therapy. Then also the role of serum iron there was also highlighted. Then we look at other advancements on omega-3 fatty acid. Sir?
The time is almost up.
Okay, sir. Then we look at advancement, then challenges, and then conclusions in terms of sickle cell anemia patient. And then some recommendations were also highlighted by Prof. So thank you very much for giving me the opportunity.
Thank you very much, Dosali, for that beautiful summary. I hope that you have gained a lot from both lecture and summary. Right, so we now move to the Q&A session. What I will do is that I will allow 1 minute questions. Everybody, please, we have to go straight to the point so I can involve as many members as possible. So give you just 1 minute to ask a question. And then you do so by raising your electronic hand. I'm happy to announce that one of our elders is the first to raise her hand. So I'm so proud to ask Mama Professor Nike Green to please throw the first shot. You're welcome, ma.
Thank you very much, Professor Guride, and our dear immediate past president. Well done. And I want to thank the presenter for a job well done. However, it reminds me of how we used to describe vaccine preventable diseases before the advent of vaccines. We would, of course, have to work very hard to manage complications of those diseases. The same thing is now happening with sickle cell disease. I don't know how many people attended, or if anybody. No, Professor Guride, you were there at the GIPP meeting where Dr. Sota Omogui spoke about giving oxygen, home oxygen, to reverse sickling of the cells, to reverse sickle cell, so that we prevent all the complications, whether it be hip problem or stroke or anything at all. All this, I hope I'm not speaking out of context, because I know that some of you were there, and I believe now that we should be able to find out, or to how this particular discovery has gone, I have been following up, and there have been many testimonies given by children, by the parents of children who treated their children at home with oxygen at the prescribed flow level, etc., the type of oxygen and all that. And what it has cost them is to buy the oxygen cylinder, which is a small amount of money compared to what it would have cost to treat the complications which usually happen. And, you know, the presenter has told us that stroke is something that is very common among sicklers. And not only that, you know, you can hardly get them back to normal. Most times they end up, you know, with their hemiplegia and all that into adulthood. So what I'm trying to say here is that let us try and follow up on what Dr. Sotamogui presented to us. If we cannot remember, can we please invite him to give us another lecture? Because I have a feeling that this discovery is going to revolutionize the way we treat sickle cell disease. I'm not saying more than that because I'm not the discoverer. I cannot give you the whole story. I think we have to hear it from the mouth of the discoverer. If Dr. Fakunle is in the audience, he can testify as well. But without that, I believe that some of you who were there, Professor Ogunrinde, I don't know, maybe you were not there, but some of you who were there, you would remember what happened at that GIPP meeting. Thank you very much.
Thank you very much, Ma. So, Dr. Park, I think I've taken note of that. So, your comment will be welcome on early oxygen therapy in children with sickle cell. Home and early home therapy with oxygen in children with sickle cell anemia to prevent these serious complications, stroke, acute chest syndrome, and other things. So maybe you want to comment on that later. So I will take another 4 if they're okay. I don't think there are any other hands raised. So a lot of questions in the chat box. So let me take 4 of them now. So Dr. Pat, are you still there? Yeah, okay. So it says
Yes, yes.
yeah. So is the regular blood transfusion irrespective of the stable PCV? And to what level are we raising the PCV to? That's a question from the individual. And then another one says, what happens when a sickle cell anemia patient? What happens when a patient with sickle cell anemia has persistent low velocities in TCD? His third one is, what is the difference between imaging and non-imaging TCD? Which is preferable? And then the fourth one, which is the fifth question for this session, please, does the bone marrow transplant change the child's genotype? Can the child who has had a transplant marry an individual with hemoglobin AA or HAS without fear of giving birth to a child with hemoglobin SS? So if you can address those 4 questions and the opening comment by Professor Grange, I think I will appreciate that. Very, very briefly.
Okay. Okay, so let me start with okay. I say, please, can EBT be done within how many hours after stroke has happened?
Those are not the questions I give. Anyways, okay. Well, go ahead. Yeah, okay.
Okay, I saw it. Once they present to you, immediately.
Can I go through something again for you? The first one is the comment about giving early oxygen at home to prevent sickle cell complications. You have any comment on that?
I think it will help, but just like in our environment, I don't know how many people can afford that, and therefore, and even if they can afford it, they need to be trained on how to use it. But that, to me, I think it can help. But just as you said, it referred to the initial speaker who may also give us a lecture on that. But to me, I think it can help. But the issue will be the logistics.
Okay, particularly in Nigeria. Okay, so the next question is the regular blood transfusion irrespective of the stable, steady state PCV? Is the level of the PCV, is it part of the decision to do a regular hypertransfusion?
Yes, while you are doing EBT or regular blood transfusion, aim not to cross 10 grams per DL, because when you cross that, the risk of increasing viscosity and sickling will come in.
Okay.
So that's the
Okay.
aim not to cross 10 grams per DL.
Thank you very much. So, what happens when a patient has a persistent low velocity in TCD? And I think there's another related question that says, is a low TCD velocity acceptable? Is it normal to have
if you have low TCD, if you have, that can occur if the window is not quite open. If you cannot access the window well, the TCD value you may not get, it may be persistently low, less than 70. But I think if it is persistent, you may not find alternative MRI, or if possible, you do angiogram to make sure there is no obstruction. But I think the commonest cause of low PCV is when the window is not well assessed. Thank you.
Thank you. So does the bone marrow transplant change the child's genotype? And is this safe for such a child to marry somebody with hemoglobin AS?
Yes, bone marrow transplant or gene therapy can change the child genotype. Because you are altering the genetic makeup. So the patient can, once they finish it, of course, they do the genotype and you find out it has reversed. So you can marry another person with AS, but sometimes I'm sure the person who has had bone marrow transplant will not like to marry a person with AS, even if, because that fear will be in him. Thank you.
Thank you very much. Well, I'm going to skip one question because, okay, let me just say, what specific measures do you employ to manage iron overload? I'm not sure whether I shall allow that question because the answer is...
So there are iron chelators that can be used. Either oral. The oral is preferable because intravenous has so many side effects. Okay. So there are oral iron chelators.
Okay. Then I think there's some questions on
Thank you, sir.
Yeah, I think there's some questions on the clinical presentation. One is, can stroke present as isolated memory impairment and personality change? And somebody asked, can stroke present with just irrational talk? So can it present with isolated or just memory impairment or personality change or irrational talk in isolation?
Yeah, we just mentioned the silent cerebral infarcts that can affect academic, and there can be memory impairment, there can be academic decline. So it's possible. As I've said, it depends on where the area of the brain where the stroke occurred. So it can affect every aspect of brain function.
All right.
Thanks.
Thank you very much. Just a few more questions. I think I will not get more because time is going. So how do you manage stroke in a child or in a patient with sickle cell anemia whose parents belong to organizations that refuse blood transfusion?
Okay, this is a legal issue. If such patient presents to me and the parents are refusing, and I know the effect it can have on the child, long-term effect, quality of life, this child is a minor, I think I will contact the legal units of the hospital. Other senior colleagues will also be informed. But I think on the whole, once I've contacted the legal units and they give go ahead that I can continue with the treatment, I will transfuse that child. What they can do is that if you transfuse the first time and they know, they will not appear to you in the hospital again.
All right.
Thank you, sir.
Very much. For individuals with indeterminate risk of okay, let me just say, okay, for individuals with indeterminate risk of high TCD, I think those are the conditional ones. What are the causes of this finding? And what is the next step for management in this situation? I think if you can just tell us about what steps to take when if somebody is having a indeterminate, conditional TCDs for a long time.
Conditional TCD velocity. Yes, what we call conditional TCD velocity is that there is narrowing, but it hasn't gone to critical point. So you need to start preventing that. The stop trial has not said go ahead with regular blood transfusion, right? But just as I said, you can start the child on hydroxyurea. The little study I just mentioned about omega can revert to normal. So that was what we can be. So there is no standard treatment for now to say go ahead with regular blood transfusion or even with hydroxyurea. But studies have shown that hydroxyurea can revert it. Probably hydroxyurea was given for other conditions, but it noted that those who have conditional velocity, with it can revert back to normal velocity. Thank you, sir.
Very much. Somebody is asking, please, how high is the risk of hemosiderosis following chronic exchange blood transfusion? Chronic exchange blood transfusion. How can this risk be managed?
I think the best is to prevent it by doing a regular iron study. Check the ferritin, serum iron, and once it's getting above normal or towards upper limit, you need to insert iron chelation therapy.
All right. Okay. So I want to believe that any child that is on regular chronic blood transfusion is at a very high risk of having hemosiderosis. Bearing in mind that the body does not have any mechanism for excreting iron, and we know the amount of iron in each unit of blood. So unless maybe we want to use automated processes, no. So let me just
yes, and that's the risk of if you are doing exchange blood transfusion, the risk is less than when you are giving the normal blood transfusion.
Okay. So let me just cap with two more questions. Okay, it says how long can one be on chronic blood transfusion? And then the second one is at what point do we switch from chronic EBT to hydroxyurea in our setting? And then maybe I'm being my own personal one. Some years ago, I met one of the people at that time clamoring for hydroxyurea, and he said emphatically that every child with sickle cell anemia should be on hydroxyurea, whether they are having a low TCD or high TCD. I mean, whether they're having whatever their TCD level is. As long as a child with sickle cell anemia, you should be on hydroxyurea. What's your take on this, please? Thank you very much.
Okay, sir. The initial stop study recommended regular blood transfusion for life. But of course, with the development of iron overload and all that, other studies have shown that once you start regular blood transfusion and you're able to lower the sickle hemoglobin significantly, you can switch to hydroxyurea and maintain the velocity to normal. Okay. Then for hydroxyurea, yes, it's been advocated that once a child is diagnosed with sickle cell anemia, you can start the child on hydroxyurea. There are some people who argue that hydroxyurea is a cytotoxic, and probably they have fear that it can also affect the renal function and other organs. So some wait until maybe the disease is becoming severe. They switch to, so they start the child on hydroxyurea. There are not every center I'm sure that there's not every center that starts hydroxyurea, because you also have to monitor regular full blood count, regular renal function estimation, and many of patients may not be able to do that. So I know that in US, in Brazil, where I went, once a child is 2 years, they start the child on hydroxyurea because they can monitor all these things we are talking about. Thank you, sir.
Thank you very much. So I wish I can stop there. I mean, that's how we can allow the parties to go. But let me just attend to 2 electronic hands. One of them is from far away, somewhere in this world. And the other one is so close at home that if I don't agree, I think he will deal with me later. So let me start by calling Dr. Farouk to ask his question or make his brief comment. Dr. Farouk, please.
Thank you, Prof, for recognizing me. Good afternoon, everybody. It's a pleasure to be here. I wanted to make some comments, although they seem to have been overtaken by events, but I think it's still important to stress it. The question about the person who had stem cell transplant marrying, we should also remember that stem cell transplantation invariably renders the recipient infertile because they have to undergo high doses of myeloablation and other things before the transplant. So they are not likely to even be able to bear children. And that's why part of the stem cell transplant process is harvesting the eggs from the females and the sperm from the males to preserve in case later they would want to have families. And in that case, it is their original genotype that they are going to have. The other contribution was regarding the patient on chronic transfusion if the packed cell volume is high. Well, that's why, again, in centers where they have the facilities, doing chronic exchange blood transfusion is the standard, not just additive top-up transfusions that we are used to. So that has 2 advantages. Number one, you are able to maintain the packed cell volume within a certain range, and number 2, you continue to reduce the HbS, and the chances of iron overload is further reduced, even though invariably they will still develop iron overload along the line. So I think those are the 2 contributions I wanted to make. Of course, the issue of the oxygen. If we look at the pathophysiology of stroke in sickle cell anemia, it's multifactorial, as had been highlighted in the presentation. So oxygen alone will not be adequate to prevent the stroke. Of course, with early intervention in any morbidity of sickle cell, there is likely to be prevention of these other complications. So last but not the least, when to stop chronic transfusion. Really, there are studies out there, the SWITCH study, the TWITCH study, that have looked at patients on chronic transfusion. As long as the patients have underlying cerebral vasculopathy, meaning the arteries have narrowed, some of these patients have to be on chronic transfusion for life, or unless they eventually get a stem cell transplant, that's when they come off transfusion. Otherwise, as the study showed, once you stop the transfusions, they will stroke again. But for those who do not have cerebral vasculopathy, meaning their MRA is clear, they don't have any abnormal vessels, after is considerable achieving the normal TCD, they can stop the transfusion and switch to hydroxyurea, and they are able to remain stroke-free. So these studies are out there, and we can consult them for further information. Thank you very much, Prof, for giving me the opportunity.
Yeah, thank you very much, Farouk. Dr. Fakunde.
Okay, so thank you, Professor Gunede, for giving me the opportunity to say a few words. First of all, let me congratulate Professor Chukwu for that very, very clear presentation. I learned a lot. So I have 2 points. One is a comment, and the other one is a question. So the comment is to ride on what Professor Professor Grange discussed about the use of early home oxygen therapy for managing sickle cell crisis or for preventing complications. I think, based on my own personal interactions with many of the people living with sickle cell disease, home and abroad, I think there's a compelling case for taking a closer look at that intervention. It's low cost. The logistics may be a bit challenging, but I think it's worth looking at. I think we spend a lot of time talking about bone marrow transplantation. That the last time I checked, it's costing 185 million naira at Luth. That was the information I got last week. And we're also talking about gene therapy. The last time I checked, it's costing $3 million per person. Even in Canada here, they are not going to touch it, because when they look at the cost effectiveness, they may not ever touch that kind of therapy. $3 million per person. Where is that money going to come from? So that's the first comment. The second point is a question to Professor Chukwu about after bone marrow transplantation. And I just want a clarification. The genotype has changed, let's say from SS to AA. Are you saying that the inheritance risk has disappeared? Because I know there's a difference between somatic gene and the germline. So can you please provide more clarification on that for me? Thank you.
Thank you very much, Dr. Fakunde. Right, so Dr. Bath, please.
Yes, thank you, sir, for the question. I think when you have done a bone marrow transplant, the genotype has changed. It's been that the risk of sickling will remarkably reduce or will disappear, and the arise. So I think that's what I can say. It will reduce because we are talking of stroke. The genotype has changed, sickling has disappeared. So these complications will most likely disappear. Thank you, sir.
I'm talking
and your
about
quality of life will markedly improve.
I'm talking about inheritance risk. Will that individual who had undergone bone marrow transplantation, what is the risk of transferring that gene to the unborn child? If that person marries, let's say, another AS or SS individual, I'm not sure what you said about whether the transmission risk has disappeared or that it is still possible for that individual to pass on the gene. I'm not talking about the role of bone marrow transplantation in managing stroke. I'm talking about a different matter entirely.
Okay, just as the last speaker spoke before you did, because of the transplant, there's ablation, and he said that some may harvest their organs in case they want children in future. I think if they do that and somebody marries AS or SS, I don't know about the relative risk, but it is a possibility. I can't say this is the relative risk, whether you will transmit it to the offspring or not. I think the geneticists may be able to answer that. Thank you, sir.
Thank you very much. I think what I can say is that normally when we ask for this investigation, we are inquiring about the blood genotype. I think whatever change in the blood when it comes to bone marrow transplant will be restricted to the blood, and I'm not sure it will affect other genotypes in the body. Unless, of course, maybe we're able to get at the very, how do I put it now, the pluripotential cells and change it from there. So I don't think that those with bone marrow transplantation will have a reduced risk of transmitting the illness to their children. Well, maybe a study can prove us right or wrong. I don't know. So I think we need to go on to the next phase of this webinar, which is the I think, is it 10 minutes now? 10 minutes by the vertex. So if the representative of the vertex is on the room, please start.
A very good afternoon, dear teachers, senior colleagues, and colleagues. Can you confirm you can hear me, please?
Yeah, loud and clear.
Thank you so much, Professor Goride. My name is Benson Uzoma, and I will be speaking to us very briefly about seeing patients as partners. I work within Novartis, and at Novartis, we are focused on reimagining medicine to improve and extend the lives of people. And part of what we have discovered in terms of reimagining medicine is reimagining medicine with the lens of the patients, beyond the lens of the HCPs and medical experts. Also take a look at medicine from the lens of the patient. My disclaimer, just to explain that so many of the things I will say today are my personal opinion and does not represent the opinion of my organization. I'll be telling us a story, and this story is around partnership. A partnership routinely is an formal agreement between one or two persons, either to operate an enterprise, or it could be a relationship, as in marriage, or an interaction between a medical expert and his or her patients. And at the end of the day, there are certain things the medical expert gains, and there are certain things the patient, on the other hand, gains. So you can see our relationship with our patients as a possible partnership. And in partnerships, there are some levels of contribution, there are some levels of hierarchy of decision making, and of course, risk and benefits that happen. If we try to take a look at a typical example of a clinical research, I'll try to drive this home. For clinical research, you see that, look at the landscape, the patients or the participants in the clinical research are at the fulcrum of the entire thing. So the operations and management run by the principal investigator or the study coordinator, or the support and execution from the CROs or the healthcare providers, and of course the regulatory organization, would have little or nothing to do without the availability of the patient and the participants. So it tells us that this group of people who are very germane to our responsibilities are not really just ordinary subjects, but indeed partners, helping us to achieve our objectives, and of course, benefiting from the great discoveries that we make as medical experts. When you take a look at partnerships, there are certain typical buckets that you will see. There's the bucket of resource contribution. There's also another one that talks about the risk and the benefits that are shared. And you look at communication as well. And then lastly, I will look at decision making. Around resource contribution for our clinical research, typically, you see that our patients contribute their time and their commitments to ensure that they keep to the protocols and that the clinical trial goes as expected. They also provide to us their samples and, of course, their data, which are very critical to the achievement of our objectives in terms of clinical research. Around risk and benefits, you observe as well that the patient has the risk of incurring adverse events on their own body, while the HCP also, yes, could also have some level of risk in terms of exposure to some of the test medications that are being given to these patients who are partnering in a clinical trial. We also see the issues around full transparency, both on the part of the patient and, of course, on the part of the medical experts as well. And then around access to new treatment, you see that the medical expert, has his job excellently done when a cutting-edge medication is now made available and his job is made easier in terms of recovery of the patient. And on the other hand, the patient is happy that he or she has taken this medication and feels better. Medical expert contributes his or her knowledge to the development of new medications, while the patient contributes his or her body and body samples for the achievement of the discovery of this new medication. Around communication, you see that definitely is a two-way thing. The medical expert communicates with the patients who are participating in this clinical trial, while the patient as well communicates, symptoms, communicates challenges to the medical experts. And we don't have a problem with this. But around decision making, it appears that oftentimes the medical expert will want to make the decisions. So, for example, we're designing a protocol, and the sponsor will typically invite medical experts to the table, and together they arrive at endpoints for the clinical trial. These endpoints are endpoints that are going to be observed in the bodies of patients, but the patients are not at the table. They are not part of the decision making. Sometimes we sit back as medical experts or even as sponsors, and we imagine that XYZ is the challenge that the patient is facing, and therefore this challenge needs to be solved, probably with a new medication or a new route to administering the medication. But the individual who is supposed to use this medication is not the medical expert, but the patient, and that individual is not at the decision-making table. Is it not a challenge that the most important stakeholder in the medical landscape, the patient for whom we have all gathered, is not involved in any form of decision? So sometimes we are in the hospital and we see, the crowd is too much. We think we need to have more clinic days to be able to attend to these patients. The funny thing is that you may reach out to these patients and discover that having more clinic days is not the solution to their challenge. Maybe starting the clinic earlier or having shorter or longer appointment days is what would feel better for them. This takes me to what we call patient engagement. It is the effective and active collaboration of patients, patient advocates, patient representatives, and of course, very importantly, because I'm speaking to pediatricians, caregivers in the process and decisions that happen around the life cycle of a medication. Let me break it down. From the bench, where we set priorities and decide to design a clinical trial, down to the bed, where our patient is now taking the medication, there are various points in which the patient can be consulted to offer some level of input and advice to this journey. So let me even go clearly to simple areas. For example, you're planning a program to educate patients around a particular health condition, for example, sickle cell disease. It will amaze you that you bring these patients together and you begin to speak to them about sickle cell disease, and it does not really make a massive impact on them. I had the situation where I brought some sickle cell warriors and advocates together, and we had some sessions and ongoing sessions as well. And they told me a lot has been said about sickle cell disease. We know a lot about sickle cell disease. However, nobody is saying anything about sickle cell traits. And if you look at it, for every pregnancy, there is a 25% chance of having a new child with sickle cell disease if the parents carry the trait. But nobody is talking about it. Nobody is shining the light on it. So this is insight that you can gather not only from your colleagues as medical experts, but from patients. I'm very glad that Dr. Fakunle mentioned something he said around the proposed use of oxygen as a potential therapy for sickle cell disease patients. He said, with my close interaction with warriors, people living with sickle cell disease, I have observed that there is a potential case for the use of oxygen. This you may not find from the books. This you may not find from looking at what happens in the hospital, but in interacting closely with these patients, in bringing them together to find out more about their disease, you may unravel certain things that can change your practice. When it comes to clinical trial as well, things around discussions around primary endpoints, secondary endpoints, general protocol design, informed consent, ethical review, there is need for us to bring some patient advocates to the table. For example, sickle cell disease patient advocacy is a very well established patient advocacy system in Nigeria, a lot of them, knowledgeable people who can provide insight from the perspective of the patient. And this would help us develop informed consent guidelines, protocols that will help our clinical trials to be excellent. Let me give you a typical example. A particular protocol was designed for a particular clinical trial. And in that protocol, the patients needed to have their bloods drawn once a month. Along the line, the patient community were brought in and asked, what do you think? And they said, of course, we will not enroll for this clinical trial. You will not have recruitment because the patients are not willing to have their blood drawn every month. Is it possible to have this blood drawn once in 6 months, and will you still be able to have your results? So I think with the very short time I've had, I've been able to tell you the story around the journey of medicine life cycle and the relevance of patients to what we do as medical experts or as sponsors to clinical trials. And then I'll leave with a question. How long do you think Novartis has been in the sickle cell space? Thank you so much for giving me the opportunity to speak, and I wish us an excellent remaining part of the evening. 57 years. Regards. Thank you.
Yeah, thank you very much, Mr. Uzuma Benson, for that presentation, for trying to nudge at our conscience. I can assure you that, well, just like you said, we have a lot of sickle cell advocacy groups in Nigeria. Some of them are very old. We used to operate with patients for a very long time now. Awesome. That we are still pursuing, but it's a good thing that you are bringing it up again. That we can, we can emphasize. I can also tell you that no matter the research you do, when it gets to the ethical committee level, we usually have representatives of patients on those committees. So they also things to be done. I can also, well, I don't know, oxygen is good. Oxygen is at the core of sickle cell disease. And I think it's good to look at the use of it in the early treatment of sickle cell to prevent complications. But we need to remind ourselves that topography of sickle cell differs in various parts of the world. I think it's particularly peculiar in our country. So I think we need to do a lot of work to get our patients to actually benefit from the advances in the management of sickle cell anemia. The one thing I would like us to also take away is that for me, I've been observing that you talk a lot about sickle cell anemia, about its management, about bone marrow, gene therapy, stem blood transfusion, counseling, but we are not yet talking about elimination of sickle cell anemia. And I think we need to start at some point to think of how do we actually eliminate it. The reason why we have sickle cell, as we suggest, to be malaria, amongst maybe some other things, but malaria is now being controlled. I asked the AI some months ago how long it will take to eliminate sickle cell anemia in Nigeria if we are able to use the most obvious solution, which is to prevent marriage between carriers. And I got a response that it takes us about 5 generations. That's about maybe between 200 and 250 years to get rid of sickle cell in Nigeria. So I want to believe that at one point or the other, we need to ask this question: how do we start eliminating sickle cell, and what ways can we use to eliminate sickle cell anemia? So having said that, I think I would like to hand over to the secretary, Dr. Tambasi, the president of PAN, is not in the house. So, Madam Secretary, please.
I am.
Oh, okay. I've been searching for you. Oh, okay. You just came in. Came late. You pay fine.
Thank you, my IPP. I didn't just come in. I'd like to sincerely apologize. I was having a network connectivity issue, so I had to call the secretary to open for me, but I've joined and for a while and enjoyed the session, especially that summary that helped me to catch up. So Pan would like to thank NISPO for this wonderful presentation. Our own IPP is part of them and it was very enjoyable. We'd like to thank all our elders that joined the session and our esteemed member as always. I see that even by the time I joined, it was already up to 164 and it went above at a point. So it's very enlightening. We also like to thank our partner, Novartis, for being a part of the webinar. We encourage such collaboration. So thank you, everyone. I guess we'll see again next month for our usual monthly webinar. God bless you.
Thank you. God bless.
Thank you very much.
Thank you, Dr. Bath.
Thank you, NISPO.
Thank you, Professor Ogunede, for excellent moderation.
Thank you very much, Dr. Fakunde.
When are you coming to see us here?
When are you coming to see us here, sir?
Just enjoy. Is that Petronella?
Yes.
I'm even vexing for you, self.
It's not possible now.
Just the chop all the oil alone in Port Harcourt.
Come and follow me now. Come.
It's okay.
So thank you. Good night, everybody.
Good night. Bye.
Good night.
I'll
Thank
catch you.
you.